And so I'm going to start. I think Ray wants to start first. So Ray is a second-year fellow, as I mentioned. He's originally from Canada. He studied CS and molecular biology at Princeton. Then he completed his residency and medical school and residency at Vanderbilt, and then earned his MPH in epidemiology and biostats at Johns Hopkins. He was inducted in Delta Omega Public Health Honor Society at Hopkins. And he, he's a metabolomics researcher and has won 2 awards at the National Kidney Forum's National Young Investigators Forum. And since coming to Yale, Ray has been productive. We've kept track of his successes. He's been an excellent mentor to trainees across the career spectrum. He created this application called gdmt.org, which was recognized by the American Heart Association. And then that application has been used by clinicians across 64 countries. He was voted by the Yale Medical Student as the most outstanding fellow teacher of the year in 2021. And then Yale Medical Residents as the Department of Medicine's 2022 Fellow of the Year. And all sheets we print out get out of date very quickly. Ray was recently awarded an outstanding alumnus from the Asian American Medical Students Association as well. So with that, I'm going to hand it over to Ray.
Thank you, Dr. Kher. Welcome, everybody. Thank you for joining us today. We're going to tell you about several key late-breaking trials from the American College of Cardiology. Of note, the live HCM study, as well as the COAP follow-up trial will be reported by Dr. Lampert and Dr. Forrest in a dedicated grand round session. So Jennifer and I chose 4 studies to focus on: the CLEAR Outcomes, STOP CA, Triluminate, and Pulse AF. We'll start with CLEAR Outcomes, which stands for cholesterol lowering via bempedoic acid, an ACL inhibiting regimen that was presented by Dr. Stephen Nissen at the ACC with a simultaneous publication in the New England Journal of Medicine entitled Bempedoic Acid and Cardiovascular Outcomes in Statin Intolerant Patients. 7 to 29% of patients report adverse musculoskeletal effects from statin use that prevents them from achieving low LDL levels, which are associated with cardiovascular benefits. Bempedoic acid is an ATP citrate lyase inhibitor, which inhibits hepatic cholesterol synthesis upstream of HMG-CoA reductase, the enzyme that statins inhibit, overall leading to an upregulation of LDL receptors to reduce plasma levels of LDL cholesterol. Because bempedoic acid is a prodrug that's activated only in the liver, not in the peripheral tissues, the incidence of muscle-related adverse events is low. And there it is in a pathway. What happened before CLEAR Outcomes? There were 4 major phase 3 trials that preceded CLEAR Outcomes. CLEAR Harmony and CLEAR Wisdom, in the blue quadrants, examined patients with ASCVD or heterozygous familial hypercholesterolemia, which they abbreviate HeFH, on maximum tolerated statin therapy. CLEAR Serenity and CLEAR Tranquility, which was shorter in duration and much smaller in sample size, examined patients with ASCVD or familial hypercholesterolemia who were unable to take statins above the lowest approved dose. Despite the different patient populations enrolled, bempedoic acid was consistently associated with significant reductions in LDL at week 12, compared with essentially no change in the placebo arm in all 4 trials. In CLEAR Harmony and CLEAR Wisdom, where patients were already on statins, the placebo-corrected change in LDL from baseline at week 12 was negative 18.1 and negative 17.4% respectively. In CLEAR Tranquility and CLEAR Serenity, where patients were not on statins, generally, the placebo-corrected change in LDL from baseline at week 12 was greater at negative 28.5% and negative 21.4% respectively. Because bempedoic acid reduced the LDL cholesterol by 17 to 28%, this prompted the FDA and the European Medicines Agency to approve it in 2020. However, until now, there has not been a trial sufficiently powered to assess cardiovascular outcomes of bempedoic acid use in a randomized manner. So what happened in CLEAR Outcomes? With a sample size of 13,970 patients, CLEAR Outcomes is already 1 to 2 orders of magnitude higher than the previous CLEAR trials you saw on the last page. This trial included adults aged 18 to 85 years who had an LDL of 100 or higher and who had intolerance to 2 or more statins, or just 1 statin if they were unwilling to attempt a second statin or were advised by a physician not to attempt a second statin. They allowed both primary and secondary prevention patients to enter. i.e. including patients who had established ASCVD and those who did not. They permitted use of any other lipid-lowering therapies such as ezetimibe, niacin, bile acid resins, fibrates, and PCSK9 inhibitors. After a 4-week run-in period, they double-blind randomized 13,000 patients in 32 countries in a 1-to-1 ratio to bempedoic acid 180 milligrams oral daily or matching placebo. The randomization occurred between 2016 and 2019. The patients were followed up for a median of 40.6 months. Premature discontinuation of trial medication occurred in 29.1% of patients in the bempedoic acid group, which is less than 31.7% of patients in the placebo group. Complete assessment of the primary endpoint was available for 95.3% of the patients, and vital status was available for 99.4% of the patients. An intention to treat analysis was performed. The primary endpoint was 4 component major adverse cardiovascular events, which consisted of non-fatal MI, non-fatal stroke, coronary vascularization, and cardiovascular death. They pre-specified a hierarchical approach to sequentially evaluate each of the 6 key secondary endpoints, starting with the 3-component MACE. Statistical significance at each step was required to formally test the next hypothesis because they wanted to preserve the type 1 error rate at 5% without having to correct for multiple comparisons. In terms of baseline characteristics, 48% was female, which is a remarkable improvement for cardiology trial standards. 30% of the patients were on primary prevention, and 70% of patients were secondary prevention. Nearly half had diabetes, and 22% were taking a statin, although this went down significantly to less than 4% by the end of the study. 11% were taking ezetimibe. The mean LDL level was 139 in both groups. Now let's look at the results. After 6 months of treatment, LDL dropped 21.7% from baseline to a mean level of 107 mg per dil in the bempedoic acid arm, whereas LDL dropped only 0.6% to a mean level of 136 in the placebo arm. After performing adjustment with a pattern mixture model for missing data, the bempedoic acid arm had a 20.3 percentage point drop in LDL level compared to the placebo arm at 6 months. This effect persisted with time. Over the full duration of the trial, which had a median follow-up of 41 months, the time average difference in the percent reductions in LDL was 15.9 percentage points in favor of bempedoic acid, or 22 mg per dil in favor of bempedoic acid. Here, you see that the time to cross into additional lipid-modifying therapy. The reason the blue placebo curves improves with time is that they permitted the addition of the other therapies, and this occurred much more frequently in the placebo group. And that's referring to the blue curve on the left graph improving with time due to what we see in the right graph. hsCRP, or high sensitivity CRP, is a established prognostic marker for future coronary events and tested in all of the lipid trials. After 6 months of treatment, the percentage change in the median hsCRP level was 21.6 percentage points lower in favor of bempedoic acid. This effect persisted with time. This is pretty good. For comparison, high-intensity statins lower CRP by 30 to 40%. PCSK9 inhibitors do not generally have a CRP-lowering effect. Now let's look at the primary outcomes. Compared to the placebo arm, the bempedoic acid arm has significant fewer incidents of the primary endpoint of 4-component MACE, which again is non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death. The hazard ratio was 0.87 with a p-value of 0.004. The absolute risk reduction was 1.6%, and the number needed to treat is 63. The reduction in 3-component MACE, which was the first of the key secondary outcomes, was actually even a bit better. The hazard ratio was 0.85 with a p-value of 0.006. You can see that both curves diverge. Fatal and non-fatal MI, which was the second key secondary endpoint, was the largest effect. Bempedoic acid had lower incidence of MI with a hazard ratio of 0.77 and a p-value of 0.002. Coronary vascularization, which was the third key secondary endpoint, was also lower in the bempedoic acid group with a hazard ratio of 0.81 and a p-value of 0.001. This result was not included in the main paper, but was included in the supplement and the ACC presentation. Bempedoic acid did not significantly lower the risk for stroke, but it significantly reduced the incidence of hospitalization for unstable angina with a hazard ratio of 0.66. Bempedoic acid did not affect cardiovascular mortality or all-cause mortality at all. However, no LDL lowering trial in the past decade has had mortality improvements. There are many reasons why this could be, including that therapies have gotten better in the past decade, and patients are less likely to succumb to MI during the short duration of a typical trial. In terms of adverse events, it's worth noting that there was not any greater discontinuation of therapy in the bempedoic acid group compared to the placebo group at 10.8% and 10.4% in each arm. The incidence of myalgias was actually lower in the bempedoic acid group than the placebo group at 5.6 and 6.8% respectively. Unlike in the statin trials, the bempedoic acid trial did not have an increase in new onset diabetes at 16.1% compared to 70.1% in the placebo group. Elevated LFTs and renal impairment was more common in the bempedoic acid group than in placebo. And there was just a 1% absolute percent increase in gout at 3.1% compared to 2.1%, and a 1% absolute percent increase in cholelithiasis at 2.2% compared to 1.2%. Now, people will ask, is the hazard ratio of 0.87, which corresponds to a 13% relative risk reduction in MACE, enough to change our clinical practice? Well, a 15% relative risk reduction moved us for evolocumab and alirocumab, which both had an 0.85 hazard ratio for MACE. So it should move us for bempedoic acid as well. Bempedoic acid is easy to take as an oral medication compared to the subcutaneous self-administration of inclisiran and currently available PCSK9 inhibitors. But in patients with statin intolerance, why would somebody choose bempedoic acid over ezetimibe when ezetimibe has a greater effect on lowering LDL? The answer to that is not clear. Note, though, that Clear Outcomes was a trial of bempedoic acid monotherapy. What happens if we add bempedoic acid to other therapies? In a phase 3 trial of patients with hypercholesterolemia and cardiac risk factors who were already on background statin therapy, the combination of bempedoic acid and ezetimibe significantly lowered LDL compared to either agent alone. So there is an additive efficacy. Whether this translates into reducing MACE further remains to be seen. Now, is bempedoic acid really more effective in primary prevention and secondary prevention? Some people have pointed out that in the subgroup analysis, the bempedoic acid effect in reducing MACE was significant at a hazard ratio of 0.68, but not significant in the secondary prevention group with the hazard ratio crossing the null. The P for this interaction was significant at 0.03. So is this a statistical play of chance? Does this mean that lipid lowering is more effective in primary prevention than in secondary prevention? That doesn't sound convincing from a biologic perspective. It's possible that there may be differences in biological mediators in the primary and secondary prevention group. It's also possible that in the secondary prevention patients, since they have already had a cardiovascular event, they're already undertaking lifestyle modifications, receiving motivational counseling, and additional non-lipid therapies to lower their risk of MACE, even though they may be in a placebo arm. In conclusion, bempedoic acid was able to lower LDL by 21.7% and high sensitivity CRP by 22.2% in patients who are unable or unwilling to take statins. This was associated with a 13% reduction in 4-component MACE, a 15% reduction in 3-component MACE, 23% reduction in MI, and 19% reduction in revascularization, although it did not affect cardiovascular mortality or all-cause mortality. Bempedoic acid was well tolerated in these patients with marginal increases in the incidence of gout and cholelithiasis. This trial only enrolled patients with statin intolerance. The effect of bempedoic acid on other populations remains to be studied. The trial also only examined bempedoic acid monotherapy. The effect of bempedoic acid as part of combination therapy is actively being studied. Nevertheless, bempedoic acid represents the latest addition to our toolkit for lowering LDL and lowering MACE by oral administration. But financial barriers, it's still very costly, and clinician inertia will need to be overcome to achieve wide use. Now, we'll change gears and talk about the STOP-CA trial. The STOP-CA trial was statins to prevent cardiotoxicity associated with anthracyclines. It was presented by Dr. Tom Nealon on behalf of him and Dr. Shara Crosby at ACC. Each year, more than 1 million patients with cancer of the breast, lymphoma, leukemia, or sarcoma are treated with anthracyclines, such as doxorubicin or idarubicin. However, anthracyclines are associated with a 2 to 10-fold increased risk of heart failure, depending on the population studied. Cardiac injury from anthracyclines begin as soon as the first cycle of chemotherapy. How does this work? The quinone moiety of anthracyclines are prone to generating reactive oxygen species, as you see there on the left, which damage DNA, protein carbonylation, lipid peroxidation, leading to cardiomyocyte dysfunction and cell death at the bottom. In addition, anthracyclines disable the function of topoisomerase 2 beta on the right side of the panel, allowing double-stranded DNA breaks to accrue, eventually leading to cardiomyocyte dysfunction and cell death. Dextrososane, which is one of the approved therapies, preventive therapies, is an iron chelator that binds free iron to prevent free radical formation and that also downregulates the levels of topoisomerase, depriving anthracyclines of the opportunity to disable topoisomerase. Dextrososane reduces the risk of LVEF drop and heart failure in cancer and is FDA approved to do so. But there are studies that raise concern for dextrososane-associated reduction in chemotherapy efficacy and possibly increased risk of secondary malignancies. Other therapies such as carvedilol have been tested prophylactically, but have been limited by hemodynamic effects. In terms of the design of STOP-CA, they looked at 18-year-old and higher patients with lymphoma scheduled to receive anthracycline chemotherapies at 9 centers in the US and Canada who were not already on a statin. The intervention was atorvastatin, 40 milligrams for 12 months, compared to placebo times 12 months. The EF at 12 months was assessed by 2D echo. Only 77% had a cardiac MRI to assess the EF. The primary outcome was the proportion of patients who had an LVEF decline of at least 10% to a final value less than 55%. And the secondary outcome was the proportion who had an EF decline of at least 5% to a final value less than 55%. The exploratory outcomes were the absolute reduction in EF by group, several pre-specified subgroup analyses based on EF change, and rates of incident heart failure. They also looked at adverse events. There were 150 patients in each arm for a total of 300 patients, of which 286 completed the trial. The median age was 52 years, and 47% of patients were women. Sex representation was good, but there was low racial and ethnic diversity. The median cumulative dose of anthracycline was 300 milligrams per meter square in both groups. 91% of the participants adhered to the study drug in both groups. Although it's not included in this table, at baseline among the entire cohort, the EF was 63%, and there was no difference in the pretreatment LDL or total cholesterol between the two arms. In terms of the primary endpoint, at 12 months, 9% of the atorvastatin group and 22% of the placebo group had a 10% decline in LVEF or more to a final value less than 55%. This means that the participants randomized to placebo had a 2.9 odds ratio of an at least 10% decline in EF compared to participants randomized to atorvastatin. The secondary endpoint, which was an at least 5% decline instead of an at least 10% decline, has similar results. At 12 months, 13% of the atorvastatin group and 29% of the placebo group had at least 5% decline in EF to less than 55%. However, when the same data expressed in the form of mean LVEF for each arm, the difference was much, much more modest. In the atorvastatin arm, mean EF declined from 62.9% to 58.8% at 12 months, which is negative 4.1%. In the placebo arm, the EF declined from 62.5% to 57.1% at 12 months, which is negative 5.4%. Thus, there was only a minor difference of 1.3% in the change in EF at 12 months between the two arms, with a p-value of 0.029. In the atorvastatin arm, LDL declined by 37%, which was expected. There were 11 clinical heart failure events with no difference in the incidence of heart failure between the two arms. In subgroup analyses, they found that the protective effect of atorvastatin and LVEF was slightly more pronounced in women, older adults above the median age of 52 years, those with more than 250 mg per meter square of anthracycline use, and those with obesity. In terms of adverse events, there was no difference in muscle pain, elevated liver enzymes, myositis, or renal failure between the two groups. Their conclusion was that in a randomized controlled trial among patients with lymphoma being treated with anthracyclines, the prophylactic use of atorvastatin over 12 months was associated with a slightly lower rate of cardiac systolic dysfunction. But what do we make of this? Statins are an easy agent to add to the toolkit of lymphoma patients. Unlike dextrososane, oncologists do not have to worry about attenuation of chemotherapy effect. Unlike neurohormonal blockade like carvedilol, statins are hemodynamically neutral. However, the effect in LVEF protection was extremely modest. It is unclear if the modest beneficial effect in EF would have been seen if the EF had been checked at a later or earlier time point than 12 months. It is also unclear how long the statin should have been continued once started. Strengths of the study include the multi-center nature, the double-blinded and randomized nature, the 95% follow-up and study drug adherence. Limitations include that it was not powered to test an effect of atorvastatin on heart failure, and it was not racially or ethnically diverse, and performed EF quantification not by 3D, but by 2D echo, which has high variability and is not the gold standard. Only 77% of the patients had MRI. The big question that this trial gives rise to, and this is my last slide, is what about the trial by Dr. Hundley and colleagues just a year before that showed no effect? That trial, which was published in NEJM Evidence, was entitled Statins and Left Ventricular Ejection Fraction Following Doxorubicin Treatment, and showed that in patients with breast cancer and lymphoma with no existing indication for statin therapy, prospective statin administration did not affect EF declines 2 years after doxorubicin. So how do we reconcile this? The first difference is that Nealon only enrolled patients with lymphoma, which usually gets 300 mg per meter square of doxorubicin, while Hundley enrolled mostly patients with breast cancer, which gets typically 240 milligrams per meter square of doxorubicin. Although it may not seem like much, but the risk of significant EF drop more than doubles with the extra 60 milligrams per meter square of doxorubicin. It has long been known that doxorubicin's effect in EF is dose dependent. The second difference is that Hundley followed patients beyond 12 months to 24 months. It is unclear the modest beneficial effect on EF seen by Nealon would have been seen if the EF had been checked at a later or earlier time point than 12 months. The third difference is that Hundley's primary endpoint was difference in LVEF, whereas Nealon's primary endpoint was proportion with at least 10% EF drop. When you dichotomize your variables, you can easily amplify modest effects. I want to acknowledge our cardiovascular prevention and cardio-onc experts, Dr. Krumholz, Dr. Spatz, and Dr. Kwan for discussing with me and rehearsing some discussion points about the CLEAR Outcomes trial and the STOP CA trial. With that, I'll pass it on to Jennifer to talk about transcatheter repair for patients with tricuspid regurgitation. Thank you.
Thanks, Ray. That was excellent. So next up is Dr. Miao. Jennifer Miao is a second-year cardiology fellow at Yale. She has a very interesting past with, she trains a classical pianist with a major in music, with concentrating on piano performance, and then studied English literature with a focus on literary criticism before deciding to pursue a career in medicine, quit for medicine. She completed medical school and residency at Vanderbilt, and her research areas of interest include cardiac amyloidosis and preventive cardiology, and her work has been published in JACC Cardio-Oncology and JAHA. At Yale, Dr. Miao is currently one of the chief cardiology fellows. She's a medical writer for ABC News, and she serves as the cardiology deputy editor for MedNet. And now, with that, I'm going to hand off the mic to her.
Yes. Thank you very much, Dr. Kerr, for that introduction. And thank you to my colleague, Ray, for those two fantastic summaries. It's a rare treat to be able to present for grand rounds with one of my closest and dearest friends from med school and residency. So today I'll be focusing on two studies that were presented at ACC, both of which also simultaneously published. The first I'll be talking about today is the transcatheter repair for patients with tricuspid regurgitation. And this was part of the Triluminate pivotal trial, which was also simultaneously published in the New England Journal. So as we all know, severe tricuspid regurgitation is a challenging case for us to treat, and it's very tough for patients to live with in terms of quality of life and recurrent hospital admissions for heart failure and volume overload. Untreated severe TR is associated with significant morbidity and poor quality of life. This is a figure from a prior study showing the burden of severe TR as it pertains to overall survival using this Kaplan-Meier curve. And you see a significant drop in survival for patients with isolated severe tricuspid regurgitation, as opposed to matched cases with trivial tricuspid regurg. So as we know, the manifestations include right heart failure, as demonstrated by peripheral edema, impaired cardiac output, and poor long-term survival. A lot of the medical therapy that we have is only centered on diuretics alone. And then the surgical options for isolated TR are also limited by the presence of RV failure and sequelae involving hepatorenal syndrome and in the setting of chronic venous hypertension. Based on the most recent ACC AHA guidelines, tricuspid valve surgery is a class 1 recommendation, but it's only reserved for cases of severe tricuspid regurgitation at the time of left heart surgery. So what is TEER or TR and what can it offer? So it's a transcatheter edge-to-edge repair. And the one that they currently have on the market, without trying to sound like a device rep, is the TriClip G4 delivery system. And then this is the figure that was included in their presentation here. As you can see, it's a delivery system that has a controlled gripper, which allows you to leverage the control sleeve. And it also has knobs to adjust both the height and the septal lateral movements that you want to optimize before the device is delivered. There's a distal curve at the end, which contains the TriClip, and it's designed for sort of direct access to the tricuspid valve. And there are 4 clip sizes. They come in either 17 or 22 millimeters in length, and there are options for the standard size versus the wider size, which accommodates a 50% wider grasping area for variations in anatomy and sort of the pathology of severe TR that the patients have. So it's a pretty neat system. It's a 25 French catheter that they use, and it's obviously done through the transvenous approach. And essentially it has a somewhat of like a V-shape or Y-shaped configuration where it approximates the tricuspid valve leaflets, and it deploys a clip to hold the leaflets together to reduce the amount of TR. So here's just the sort of clips from the Abbott demonstration video. You see the septal posterior anterior leaflets. You can see the sort of Y-shape or V-shape configuration of the clip as it approaches the tricuspid valve, and then it expands. And then there are 2 smaller sort of Y-shaped configurations attached where it hooks onto the atrial surface of the tricuspid valve leaflet and sort of holds everything together. And then this device permanently opposes the tricuspid valve leaflets. So the study design was fairly interesting. It was a randomized control trial. So this was in collaboration with Abbott, who obviously manufactured this. They enrolled patients with symptomatic severe TR and at intermediate or greater risk for tricuspid valve surgery. It had an echo core lab, which confirmed the severity of tricuspid regurg. And then the patients were then randomized to either the device group, which included 175 patients, versus the control group or medical therapy alone. And then follow-up was conducted at 1, 6, and 12 months. In terms of the inclusion and exclusion criteria, the key things that they wanted to highlight in their presentation were severe symptomatic TR for those who were included. And they had to be on stable GDMT at the time and or device therapy for heart failure for greater than 30 days. So this did not exclude patients with devices. And they had to be at least intermediate risk of mortality and morbidity with tricuspid valve surgery. Additionally, they wanted to focus on patients with severe symptomatic TR with elevated PA systolic pressures, but those of which were less than 70 on standard GDMT. And they excluded patients with concomitant valvular conditions, such as severe AS, MR, and who were otherwise high-risk surgical candidates. Additional exclusion criteria were severe pulmonary hypertension or an EF of less than or equal to 20%. Additionally, you had to have an anatomy that was suitable for triclip therapy. If not, you were excluded. So this is our own, this is sort of like an outline of the institutions that were involved in this RCT. And you'll see that on the far right, Yale is actually part of it too. And they assessed the patients at 1, 6, and 12 months following initiation of either medical therapy alone or triclip. And this was assessed through their symptom assessment, a 6-minute walk test, and quality of life measurement with the Kansas City Cardiomyopathy Questionnaire, the KCCQ. The scoring system ranged from 0 to 100, with the higher scores indicating better quality of life. So the primary endpoint that they looked at was after the first 350 randomized subjects completed 12-month follow-up was a composite of mortality or tricuspid valve surgery, heart failure, hospitalizations, and quality of life improvement of greater than or equal to 15 points as based on the KCCQ evaluated at 12 months. And then they used an interesting statistical method I'll get to in just a little bit, the Finkelstein-Schoenfeld method to assess the group that wins ultimately. The secondary endpoints they looked at from the study were freedom from major adverse events after procedure attempt at 30 days in the device group only, of course, change in KCCQ at 12 months, TR reduction to moderate or less at 30-day post-procedure, and then change in 6-month walking distance at 12 months, or 6-minute walking distance at 12 months. So this is an interesting statistical method that was employed for the study. It focuses on the idea of which group wins. This was used with the Finkelstein-Schoenfeld method and the idea of what is called the win ratio, which I think is being increasingly used in cardiovascular randomized control trials. And this model really allows us to combine the time to event and longitudinal measurements using outcomes arranged in a hierarchical distribution based on level of importance. So like what the study investigators consider to be important events. The benefit of the treatment, aka significantly more wins than losses, was defined by a ratio greater than 1. And then all possible pairs of one patient from the TER group and one patient from the control group were used for comparison. And then this essentially, they divided the number of pairs in which a patient in the TER group has better outcome than the patient in the control group, i.e. that would be defined as a win in the TER group by number of pairs in which a patient in the control group has a better outcome than a patient in the TER group, which is a win for the control group. This is just an example of like a simplified illustration of what the win ratio method technically would look like. So you have any combination of patient pairs, one involving the treatment group, one involving the control group. So as defined by A or B, and then you look at the time to first event. If you think about, MI, stroke, or death, and you want to prioritize MI, then you see who has an MI event earlier. And then so the win ratio, there are two potential outcomes that are outlined here, the win ratio 1 and the win ratio 2. In the win ratio 1 group, the hierarchy was death greater than MI greater than stroke. And then so the win ratio 2 group was death greater than stroke greater than MI. So taking a look at which of the 2 patients in each of these combination groups had an outcome earlier. And so they would be, unfortunately, the group that loses. And then the patients that have the adverse event outcome later would be the one who technically wins. So the population that they looked at here both 175 in the device group and 175 in the control group. The mean age was 78 and roughly for both of these groups. There were about slightly over 50% were female. And the vast majority had NYHA class 3 or 4 symptoms already. Additional comorbidities, they had hypertension, renal disease, liver disease, and a fair amount, 87 and 93% had AFib as well. And then roughly a quarter had a prior mitral valve intervention in both of the groups, and about 15% in both groups had a prior aortic valve intervention or also had CRT, CRTD, ICD, or pacemaker implantation. There was only one person in the prior tricuspid intervention in the device group that had a prior tricuspid intervention. The control group didn't have any. In terms of the degree of TR that was seen, the majority of the patients had torrential TR. And then about a quarter, 18 to 20% in both groups had massive TR. And then a quarter had severe TR. And there were only a handful that had moderate TR. And the majority of the patients with TR in both of these groups had functional TR. And then there were additional echo parameters that were assessed and measured. So the primary endpoint results were ultimately, they looked at the hierarchical composite of death from any cause or tricuspid valve surgery, hospitalization for heart failure, and improvement of greater than or equal to 15 points in KCCQ scoring at 1 year. And that tallies the number of wins. In the TR group, there were 11,348 wins. The control group had 7,643 wins. And so the difference is, a win ratio of 1.48, which is ultimately significant. Death from any cause or tricuspid valve intervention occurred in 16 patients in the TER group and 18 patients in the control group. And then the annual heart failure admission rate was 0.21 events per patient year in the TER group and 0.17 events per patient year in the control group. And so in terms of the overall outcome for the primary endpoints, which were sort of ranked based on level of severity of outcomes, I suppose, for the investigators, looks like overall the TR group wins. Notably, they looked at how quality of life changed. So quality of life significantly improved for the TR group as defined by KCCQ scoring. And 73 out of 147 patients in the TR group versus 39 out of 148 patients in the control group had a 15-point or greater improvement in KCCQ score at 12-month follow-up. The magnitude of change consistently favored the TR group when adjusting for subgroups based on demographic features, comorbidities, right heart size, and function. In terms of the secondary endpoints that they looked at a Kaplan-Meier estimation of patients with freedom from major adverse events through 30 days after the procedure. They looked at change in KCCQ score from baseline to 1 year, and they looked at tricuspid regurgitation of no greater than moderate severity at 30-day follow-up. Additionally, they assessed change in 6-minute walking distance test from baseline to 1 year. And they saw that the freedom from major adverse events following TER through 30 days after the procedure was 98.3%. And then this actually exceeded their performance goal of 90%. Deaths from kidney failure happened in 2 patients, and 1 patient death occurred after hospital discharge, where the patient was then readmitted for a non-cardiac procedure. And then again, to reiterate the changes in quality of life, the KCCQ score increased by a mean of 12 in the TER group and 0.6 in the control group. So that's a notable difference, P of less than 0.001. The delta KCC score associated with the degree of residual TR and magnitude of TR at 1 year follow-up was also notable. The scores increased by 15 points among patients with moderate or less residual TR at 1 year versus 3.8 points among patients with severe or greater residual tricuspid regurg. So basically you feel better if your valve is fixed. Secondary endpoints, looking at severe TR TR severity at 30 days. You have 140 out of 161 patients in the TER group and 7 out of 146 patients in the control group had tricuspid regurg of no greater than moderate severity at 30 days. So obviously a notable difference between the control arm and the medical, and the device group. And additional, there were, like I mentioned, a total of 3 major adverse events in the device group, including renal failure and cardiovascular death after being readmitted for another reason. So in conclusion, the TriClip therapy reduced TR to moderate or less in 87% of patients compared to a reduction in TR severity in the control group with medical therapy alone of 4.8%. TriClip therapy wins with the win ratio of 1.48, and this demonstrates device superiority with the main outcome contributing to win being significant improvement in quality of life. TR reduction using TriClip therapy led to improved quality of life at 1 year follow-up, and there was a low 30-day major adverse event rate of 1.7%, with death and pacemaker implant occurring in 0.6% of cases. The next study I'll talk about is the pulsed AFib trial or post-AF trial, pulsed field ablation to irreversibly electroporate tissue and treat AF, which was also simultaneously published in Circ. So as we know, AFib is a sort of long, drawn out pathologic disease process. It's a progressive electoral and structural remodeling process that occurs, leading to longer lasting forms of atrial fibrillation over time. 8 to 15% of patients over 12 months will progress from paroxysmal AFib, as defined by less than 7 continuous days, to persistent AFib, or lasting 7 or more continuous days. And then this figure here highlights, without preventive treatment, AFib recurrence is estimated to be 75% over 1 year. First-line antiarrhythmic drug therapies only have a modest effect at maintaining normal sinus rhythm long-term, hence why ablation exists. So with developments in catheter ablation, people looked at, can this be a better option for patients in terms of halting the pathoanatomical changes that you see with progressive AF? And then this was performed through 2 notable studies, MANTRA PAF study, which demonstrated a decrease in AFib burden following radiofrequency ablation at 24 months compared to the antiarrhythmic drug group. However, the cumulative AFib burden was similar. And then the RAF study, which again looked at reduction in AFib burden post-ablation compared to the antiarrhythmic drug group. However, recurrence remained frequent between these 2. And in terms of what radiofrequency ablation can offer, it does have its risks. So traditional thermal ablation, as we know, is associated with incidence of esophageal injury, phrenic nerve injury, and pulmonic vein stenosis. And pulse field ablation came into play because it has a unique way of creating lesions non-thermally using electric field gradients. And this changes the cell membrane permeability, the myocytes. And this promotes cell death and apoptosis without actually compromising protein denaturation or tissue scaffolding. So it's a transeptal approach, as you can see here. The catheter is introduced into the left atrium over guide wire. The ACT goal throughout the entire time was greater than 350. They administer a circular array of pulse field ablation catheter that was positioned at each pulmonary vein ostium, which was guided by TE and fluoro. And then one application was equal to 4 biphasic bipolar pulse trains lasting 100 to 200 milliseconds at 1400 to 1500 volts. And then after each application, the catheter then rotated circumferentially to a new position. So essentially using the idea of electromagnetic fields to simulate cell apoptosis by directly impacting the cellular permeability in the cell membranes without zapping anything through heat. The study design, so it was a non-randomized paired single-arm study and enrolled patients with proximal, paroxysmal, or persistent AFib that was refractory to class 1 or class 3 antiarrhythmics. The follow-up time was 12 months post-ablation, and this also excluded the standard 90-day blanking period that patients have. EKGs were obtained at 3, 6, and 12 months, and 6 and 12-month 24-hour Holter monitoring was also done. Patients were enrolled if they had failed previous antiarrhythmic drug therapy, and if they were diagnosed with paroxysmal persistent AFib, and the age range was 18 to 80 years old. People who were excluded were those who had longstanding persistent AF, a left atrial diameter of greater than 5 centimeters, prior left atrial ablation or surgery, and those who had not been on systemic anticoagulation for at least 3 weeks prior to the procedure. They looked at a few endpoints. The primary effectiveness endpoint was freedom from composite of acute procedural failure, such as the inability to isolate all pulmonary veins or any ablation requiring additional non-study devices. They looked at arrhythmia recurrence greater than 30 seconds post-ablation or antiarrhythmic escalation through 12 months following the blanking period. They look at the primary safety endpoint, which was freedom from composite of serious procedural and device-related adverse events, which were adjudicated separately by a clinical events committee. In terms of secondary endpoints, they looked at the quality of life based on the AFib effect on quality of life, AFEQT score, and Life 5 Dimensions questionnaire. So of the 383 patients that were enrolled between March and November, 300 were ultimately included in the primary analysis. On average, there were 5.8 or 6 patients that were treated per ablation per operator. And then adherence was fairly reasonable to follow-up time as through Holter, EKG, and scheduled telephonic transmission data for both cohorts at 86, 90, and 81%. So they found that it's actually achievable. So pulmonary vein isolation was achieved in 100% of these cases for both cohorts. And the highlights include that the mean time from the first and last application of the pulse field ablation was about 58 minutes and 64 minutes for the paroxysmal and persistent cohorts, respectively. The mean time for post-field ablation energy delivery was 25 seconds each time and 29 seconds for the 2 groups. And the performance goals were previously established using data from the most recent guidelines, which was a greater than 50% performance goal for paroxysmal cohort and then a 40% goal for the persistent cohort based on sort of prior consensus statement on catheter ablation. And in terms of the primary efficacy endpoint results, so both cohorts achieved performance goals as measured by freedom from acute procedural failure, arrhythmia recurrence, repeat ablation, direct cardioversion, left atrial surgery, antiarrhythmic direct escalation through the 12-month period. So the performance goal that was met for the paroxysmal AFib group was actually 66.2%, which exceeded the pre-specified performance goal of 50%. And then for the persistent atrial fibrillation group, it was 55.1%, which exceeded the pre-specified performance goal of 40% at 12 months. And then they looked at atrial arrhythmia recurrence and clinical success findings at 12 months. They found that 79.7% of patients in the paroxysmal AF cohort had freedom from any symptomatic atrial arrhythmia. And then similar findings in the persistent AFib cohort. And then freedom from any sort of atrial tachyarrhythmia, AT, AF, A-flutter recurrence was notable. So 69.5% in the paroxysmal AFib group and then 62.3% in the persistent AF group. So like we said earlier, both cohorts met the pre-specified performance safety goals. And there was one case of a stroke on the same day of the procedure for the paroxysmal group, one case of a pericardial effusion requiring drainage, One patient died from liver failure, and one patient died of cardiopulmonary arrest 2 weeks after Bempedoic was initiated. In terms of quality of life, there was statistically significant improvement in quality of life post-ablation for the paroxysmal AFib cohort. The mean improvement of 29.4 points at 12 months for the paroxysmal AFib cohort. This was established using the AFEQT scoring system. There was also a mean improvement of 0.05 points at 12 months using the EQ5D5L scoring, which was also considered significant. And then this is for the persistent cohort. So again, seeing an improvement in quality of life post-ablation for both of these groups. The secondary endpoints that they looked at were pre and post-ablation imaging at selected centers. So they looked at brain MRIs, pre and post-ablation, and they found that only 4 cases had new post-procedural silent cerebral events. Pulmonary vein stenosis findings. So there were actually no reported cases of moderate or severe pulmonary vein stenosis observed between baseline and 3-month imaging among 63 patients. So in conclusion, pulse field ablation is a safe procedure. 0.7% primary safety endpoint rate for both groups, which met safety performance standard goals of less than 13%. And there were no cases of chronic esophageal pulmonary vein injury or coronary artery spasm observed. For both the paroxysmal and the persistent AF groups, they met effectiveness performance goals at 12 months following pulse field ablation. Pulse field ablation also significantly improves quality of life, and it was associated with a 79.7 and 80.8% clinical success rate as measured by freedom from symptomatic atrial arrhythmias for both the paroxysmal and the persistent cohorts at 12 months post-ablation. Okay, thank you very much for your time.
Perfect. Thanks so much, Ray and Jen. I think the key goal for this session is to prompt discussion, but the discussion shouldn't be pointed at the fellows because they didn't lead the studies. But I think we have experts, faculty in the room, and so any questions regarding clear outcomes or any of the trials, please feel free to. We have about 5 minutes to talk about stuff. There is. Sorry, one second. Going one, twice.
On the that statistical approach seems to some of the statistical approach.
Especially if you have multiple endpoints that you're tracking, it allows you to really weigh specifically the value of different endpoints. And I think all these approaches, this is approved for FDA FDA trials. So in a way, it's emerging. But again, if it stands up in terms of a trial specifically tested Cox proportional hazard model that we're used to versus this, if you would see a difference in the two for a same sort of endpoint, it's the early study suggests that you won't. It's only adding additional information beyond what we already found. And I mean, thanks for spending the time kind of reviewing it for the group. And I'm hoping we'll see more of these so we can actually critically evaluate them properly. There are a couple of comments. One comment from John, and Eric has a comment. So I'm going to read out the comment from John because I started reading it. And then I'll have a comment from Eric. Important to note that there was not a sham arm, and as such, patients knew if they had procedure or not. Unfortunate that there wasn't even a trend towards benefit for other endpoints, including hospitalizations. We know people feel better after procedures, even after a sham sternotomy. And I wonder if this is about TEER or it's unclear to me which procedure.
It's about.
Okay, perfect. Yeah. Thanks, John. Great point that the sham procedures themselves may have a placebo effect of sorts. Eric?
Yeah, first of all, thanks to Rui and Jennifer. Very nice job presenting comprehensively these programs. I have a question to Jennifer regarding tricuspid regurgitation quantification. And so this is one of the, I think, challenges in this field as it develops, because we don't have a kind of, I would say, we were developing a methodology, but that methodology has been questioned around the massive, submassive, all the different terminologies they're using. I wanted to get your sense, based on your experience to date in our lab here, and in how do you feel that those, what confidence do you have in that methodology, and what are the pitfalls that you might suggest exist in terms of quantifying TR as an endpoint?
Yeah, so I think that they didn't go too much into detail about how the core lab that they used had determined the severity of TR. I think it was just based on standard methods that we have. I think it's a good question. I don't know, actually, Dr. McNamara, if you are able to comment more on.
Yeah, this type of quantification grading of the tricuspid regurgitation is pretty controversial in the echo world. I mean, this clearly was something to try to differentiate people with different grades of tricuspid regurgitation. So it's, we have a lot of severe TR, and then they were trying to figure out whether patients that had even more than would typically be thought of. But something for a trial like this, I think it was important, and they're trying to quantify whether to go from severe, massive, torrential. It's going to be very difficult in non-quantification, and in the general lab, even here, but certainly across the country, the quantification of TR is very limited. So I think it works in the clinical trials. We'll see whether it's going to go further and whether it really matters. I mean, they can show differential prognosis of patient based on the quantification. So people with torrential have a worse prognosis than people with massive have worse prognosis than severe, although it's somewhat, haven't really shown that treating them any differently has shown anything.
Thanks.
Bempedoic acid, as you know, is actually, as I mentioned, cyclic ligands. The precursor and regulates cyclic photosynthesis, but also gluconeogenesis. And I was wondering if there's any differences if you take diabetes to take it, whether we're going in future kind of abilities instead of statin, although effects like the statin is still a lot larger. But is there any effect on the glucose patient with diabetes? That's one number. Another thing is that you got little a can be inhibited by K9, and is there any data on that or any study going on to affect the Bempedoic acid on the?
Those are really great questions. I don't know the answer to those, but for what it's worth, in the oh, that's okay. Well, it's not a huge thing anyway. Every single one of these trials had a huge percent of diabetes patients represented. So I'm sure that somebody has done a subgroup analysis for diabetes.
It's probably pre-specified.
Yeah. Yeah. See, 30% diabetes in pretty much all of them, and Clear Tranquility had 19%. And then as I mentioned in Clear Outcomes, the incidence of diabetes was not higher in Bempedoic acid versus placebo. But I don't know about the lipoprotein little a.
Yeah, I mean, I wonder if the effect of, we'll probably know the effect of muscle versus liver on diabetes. And if there, the statin specific effect is both liver plus muscle. And Bempedoic acid is liver specific because of its prodrug formulation. It'd be interesting to see what happens to, hyperglycemia management over time. Very interesting. Perfect. No, I think we're on time, and I appreciate both Ray and Jen for taking the time and walking us through these trials. Thanks again.